Hi, everyone. Today I'd like to talk about abnormal puberty in pediatrics. So this is the second video of the video lectures for the academic half day. This will be included on the section on April 22nd. So I hope that you have a chance to review before the session. So before we talked about puberty, I'd like you to introduce you to the physiologic control of the endocrine system. Most of you are familiar with this feedback loop. Most of the endocrine glands are under the control of pituitary gland, which is also under the control of hypothalamus. So we often think of hypothalamus and pituitary as one unit for the simplicity of the differential diagnosis. So the hypothalamus secretes releasing hormones, right? So you'll see at the end it has that RH, like GnRH, TRH, GHRH, like those indicates the releasing hormones. Um, it then stimulates pituitary to secrete stimulating hormones, right? So FSH, LH, TSH, right? So those that ends with SH, right, which is denotes stimulating hormones. And these stimulating hormones then activates the endocrine gland to secrete the hormones. And once the hormones bind to the target organ sends the feedback signal back to the hypothalamus and pituitary to complete this feedback loop. Right? So the abnormality that occurs at the endocrine gland is considered a primary cause, right? We often call it primary. And then, whereas the abnormality that occurs at the hypothalamic pituitary is called secondary. So you may have seen the term that is call some of these conditions primary and secondary. So we will apply this concept for the other hormone systems as well. So as for puberty, this unit is called hypothalamic pituitary gonadoaxis, or HPG. So the hypothalamus secretes gonadotropin releasing hormone, or GnRH, which then stimulate pituitary to secrete FSH, LH, together term gonadotropins. Finally, gonadotropin stimulates gonads to secrete sex hormone, which is estrogen for girls and testosterone for boys. The HPG axis is not always activated. It is activated during in utero period, especially during the sexual differentiation. It then becomes quiescent during childhood, and then it is activated again during puberty onset. So you could see here there's a variation in the timing of the onset of puberty. Some children will start puberty sooner than the others. So the important part of evaluation of a patient with pubertal concern is to determine whether this patient actually has abnormal onset of puberty or not. So before we can determine if someone has an abnormal puberty, we have to understand the normal timing of puberty. So this is when the statistics come into play again. So in girls, the average onset of puberty is between 10 to 12 years, with one standard deviation of 1 year. And for boys, with between 12 to 13 years, with the standard deviation of 1 year. So we often think of a normal or acceptable range between -2 SD to +2 SD. So therefore, in the definition of precocious puberty in girls, right? So it's 10 minus 2, which is come from 2 times 1. So it's 8 years, whereas boy is 10 years. So um, if a girl has a pubertal development before 8 years old or 10 years old in boy, they're considered to have a precocious puberty. Same thing for delayed puberty, right? So it is 2 standard deviation outside after the average onset, right? So it's 12 plus 2 in boys, and girls is 14 years, and in boys is approximately 14 plus 2, which is 14 to 15 years. So we use an approximation. So the definition of delayed puberty in girl is if um, a patient does not have pubertal development by 14 years in girls or 14 to 15 years in boys, we consider that delayed puberty. There's also another definition for delayed puberty. If the pubertal development is not completed by 5 years, it is also considered delayed puberty. So the next step is to do a pubertal staging, which is also the very important step in determining whether a patient does have um, abnormal puberty or not. So we have to understand that the first sign of puberty that is controlled by HPG axis or central puberty is testicular enlargement in boys and breast development in girls. So this is the picture that indicates the staging of the breast development. So we often, the way I remember it, I remember Tanner 1 and Tanner 5, right? So Tanner 5 is a full breast, Tanner 1 is nothing. And Tanner 2 is when you have a very small amount of breast tissue under areola, where Tanner 3 is when the breast tissue is expanded beyond areola. And Tanner 4 is when you have the secondary mounting. For testicular volume, it is a little more difficult to remember because it is indicated by the size of the testes, which is in cc. So the way to remember is that if you have a testicular volume that is bigger than 3.5 cc's, it is considered a pubertal size. And the fully developed testes is 25 cc's. So in the board exam, they often give you the testicular size that is quite obvious, right? So anytime you see that the question gives you a testicular volume bigger than 3.5 cc's, that's considered a pubertal size of testes. Um, and the penile enlargement will come after the patient produce enough testosterone, right? So it often occurs that between 10 or 3 to 4. Now for pubic hair, if it's the only sign you see in girls or in boys, that is not a sign of central puberty, right? Because the androgen often come from adrenal gland, or we call it adrenarche, right? In boys as well, if you do not see any testicular enlargement and you only see pubic hair development, that's also considered adrenarche, right? The way to do the Tanner staging for pubic hair, same thing. Remember Tanner 1 and Tanner 5. 5 is fully developed. Tanner 3 is when a patient has pubic hair that covers just mons pubis, right? And Tanner 4 is expanding beyond mons pubis. So that's the Tanner staging for pubic hair. So what do we do when we see a patient with concern for pubertal development? Again, we'll go back to the basic, right? So we have to confirm the onset, right? This is one of the most important piece of the history in order for you to determine whether the patient has pubertal problems or not, is the onset, right? So you might want to ask the parent, when is the onset? And often you'll find that there's a family history of either delay or early puberty. And then you review growth chart to see is there any recent growth acceleration or a slowdown in growth, because you often see that in patients with precocious puberty, they often have a growth acceleration as well. Then the next step will be to do a complete Tanner staging, right? A complete physical exam, not just Tanner staging, but you will pay attention to the Tanner staging. And again, if you only see pubic or axillary hair development without testicular or breast development, that is not considered a central puberty, right? So it indicates that the androgen comes from peripheral source, which is the most common source is adrenal gland. And then you follow them with laboratory tests to confirm whether is this a central puberty or not. And then many of you often send bone age. And I believe that I have stressed about this issue many, many times, that we all send bone age. Almost all patients with endocrine problem will have a bone age done even before a complete history of physical exam. Never do that because it will confuse you. Um, let's go back to precocious puberty again. So by definition, is the development of puberty earlier than the normal onset, right? So you need the onset from the history and you need a physical exam to confirm. If you have a physical exam that indicates pubertal development, and you also have the onset that is earlier than normal timing, you have it. That's considered precocious puberty, regardless of the bone age. So, what laboratory tests should you obtain when you see a patient with um, pubertal problem, right? So now it depends on whether you think this is a central puberty or this is a peripheral type, right? So if you think this is a central precocious puberty, you would send gonadotropin along with the sex steroid, either estradiol or testosterone. But if you think this is a peripheral type, so you want to look for the possible sources, right? And again, the most common source of peripheral pubertal development is the adrenal gland. So this is when you will send an adrenal hormones. So there will be another video lecture regarding the adrenal pathology. So in that video, you will see examples of case where you would think of obtaining adrenal hormones. So for causes of precocious puberty, going back to the endocrine feedback loop that we talked about earlier, we need to come back to this um, loop in order to understand the pathology. So if the cause is at the gonads or adrenal gland, right, this is considered a peripheral cause. Whereas if the cause is by the pituitary or hypothalamus, this is considered central, right, which is often driven by gonadotropin, right? So we call it central precocious puberty. So for the etiologies of precocious puberty, for central causes, we often think of central lesion, right? However, the most common cause of precocious puberty is idiopathic, especially in girls. Other central lesions, such as hypothalamic hamartoma or brain tumor, which is counterintuitive because you think of a brain tumor as a destructive lesion. However, in some cases, the brain tumor disinhibit the suppression of the HPG axis, causing the puberty to start earlier. Or a patient with cerebral palsy. There is also a syndrome that can cause central precocious puberty. It is considered a neurologic syndrome with a lot of skin lesions. So I want you to look that up to see which syndrome is that that can cause central precocious puberty. Now, for peripheral cause, right? So on the laboratory exam, you're going to see a very suppressed gonadotropin levels with elevated sex steroids. Again, the most common source is adrenarche. And luckily, majority of the case will have a benign premature adrenarche, right? So the adrenal gland just starts secreting androgens without a true pathology. We call it benign premature adrenarche, right? Or a more severe pathology is either gonadotumor or you have other adrenal pathologies such as CAH or adrenal tumor. So we're going to come back to talk about these adrenal pathology in another video section for the adrenal pathology. So there are syndromes that are worth reviewing. One of them being McCune-Albright syndrome. So you often hear this a lot, especially the board exam love this syndrome. So the definition of this syndrome is the constellation of three clinical findings, right? A very large cafe au lait spots, fibrous dysplasia, or precocious puberty. So the interesting thing about precocious puberty in McCune-Albright is that they have signs of central puberty, right? But is the pathology is due to the activation of G protein that is associated with FSH and LH receptor. So the receptor is activated, right? You have an action of gonadotropin, but the FSH LH itself will be suppressed, right? So we are considering this as a peripheral type, right? So when you do the blood test, you're going to see a suppressed gonadotropin levels, right? For delayed puberty, so we'll apply the same principle. If the pathology is at the gonads, we call this a primary cause. So when you obtain laboratory tests, you often see a very elevated FSH and LH, right? Whereas the secondary causes, you're going to see low to normal gonadotropin, right? So primary and secondary. So for primary cause, we have a fancy term called hypergonadotropic hypogonadism, right? Sounds very confusing. It's a hypergonadotropic hypogonadism, right? Which indicates the primary cause, right? So the most common are genetic causes, right? Turner syndrome, right? We talked about it in the growth video, right? This is a primary gonadophilia because the ovaries are poorly formed, right? You often see a streak gonads, right? So um, when you do the blood test, you're going to see a very elevated gonadotropin, right, in Turner syndrome, right? And they have a very delayed puberty. For boys, the most common cause of delayed puberty as a genetic syndrome is Klinefelter, right? So Klinefelter syndrome, always also review the clinical features of Klinefelter. It's often come up on the board exam. So it is in an extra X chromosome, right? In an XY individual, right? So you have an XXY karyotype causing a testicular failure, right? So they often have very small testes, right? And if you see the histology, it's very dysgenetic testes, right? So they have delayed puberty. Some of them can make a small amount of testosterone to advance the puberty, right? But they often stuck at certain stage of pubertal development, right? So genetic cause. So review those two syndrome, Turner syndrome and Klinefelter syndrome. Now you can also have patients receive chemotherapy, right? Cyclophosphamide is one of the examples that's very toxic to the gonads, right? Or the radiation injury, right, to the gonadal area. Now, as for secondary cause, we have also a fancy term, right? This is a central, right? So we call it hypogonadotropic, hypogonadism. So hypogonadotropic meaning that gonadotropin's levels are low to normal, right? So we think of a central lesion, right? Any brain tumor, right? Or a patient with brain tumor that receives surgery, radiation, right? So it caused injury to hypothalamic pituitary unit or any chronic diseases, right? So in a chronic disease, it can disrupt the HPG axis, right? So you have very low gonadotropin, right? So it can cause a hypogonadotropic hypogonadism, right? Anorexia is one of them, right? So it's because of the severe calorie restriction, it affects the HPG, right? Or there are two genetic syndromes, right? So one is Coleman syndrome. So Coleman syndrome is a genetic syndrome caused by the abnormal formation of gonadotropes, right? A cell that secretes gonadotropin. They also have the very hypoplastic olfactory bulb, right? It came from the same embryonic origin, right? So a patient has anosmia, right? So when you see a question to describe a patient with anosmia and delayed puberty, think of a Coleman syndrome, right? And Prader-Willi, right? So we mentioned earlier about Prader-Willi in another video, right? So they have obesity, short stature, severe developmental delay, and they also have central delayed puberty, right? So they have very low gonadotropin. So this is all I want to review for now. We're going to go through cases with pubertal problems during our session. So thank you so much for listening.